as time goes. In the meantime, would like to just wait a little bit for a few more, for maybe another 5 minutes for a few more people to join us. Also remember, for some of your colleagues who might join you in the forum is full, this talk will be live streaming on YouTube. Dr. Cornelia is going to share the link to the YouTube channel on the chat. Kindly follow that or share that with your friends who might not be able to join us from your different fora. So in general, we know that fluids are probably the most widely prescribed medical intervention in hospital, everywhere, anywhere, and it starts right from the smallest health unit, the dispensaries, all the way to the most complex health units. And this are used everywhere in healthcare, on the general ward, in emergency rooms, in the, in the operating theaters, the ICUs. It's probably the commonest therapy that is administered. And unfortunately, not all our practices around fluids are actually based on evidence, but there's also quite significant evidence that some of the practices around fluids are actually harmful. So hopefully today's talk will help us to appreciate a lot more how to use fluids in ICU, as well as in operating theaters, and also for patients who are maintaining just on the therapies. So kindly pay attention. As usual, save your questions for the end of the chat. In terms of our menu, we have got a presentation of a clinical case which represents a day. That's going to be presented by one of our senior residents in emergency medicine, Dr. Asimwe Kemigisha. And then we shall go to the basic science around fluid therapies and the vasculature, a talk on the revised Starling principle and endothelial glycocalyx, which underlies some of the therapies that we do. This will be presented by Dr. Orichiriza Joshua. Thereafter, we shall talk about how to use fluids for resuscitation, for maintenance, among other things. And this will be presented by one of our ICU fellows, Dr. Peter Waswa. And finally, we shall have staff specialist intensivist take on cardiovascular medicine and the use of albumin, particularly in care of the critically ill, presented by Dr. Timothy Muyimbo. So currently on your screen is Dr. Asimwe's talk, which will be going on in a bit. But before we proceed, as we wait a little bit, I would like to ask Dr. Cornelius to run the poll question. Then we shall proceed. Thank you. Dr. Cornelius, over to you.
All right, thank you, Dr. Erasmus. I'm going to launch the first poll questions, and this will be on the topic that we shall be covering in the next session. So here it is. There are about 6 questions. Please feel free to respond to them, and after the second talk, we shall discuss these. So the first question is about normal healthy adults and the intravascular half-life of isotonic crystalloids. You can select whatever half-life you think is correct. If you don't know the answer, just pick one. We shall still discuss it. We are all here to learn. And then the second question relates to colloids, intravascular half-life of colloids in the healthy adult. Again, just select which of the options there is you think is correct. And then blood volume expansion, colloid to crystalloid ratio, approximately what would that be, either from what you know or what you've read. You can select whatever option. And then number 4 is about fluid shifts, whether fluid is reabsorbed back into the capillaries, or it's filtered at the end and only moves in one direction, or oncotic pressures in the interstitial space are low or high. What do you think? And then whether albumin administration increases fluid absorption from the interstitial space. And then number 5 is about the endothelial glycocalyx layer. Which of the following is false? You can select whatever answer there is correct. And then what can damage the glycocalyx layer? So you can select any of the options that are appropriate. So we have about, which I'll probably hand over back to Erasmus when we, I think to the presenter of the past talk, once we hit approximately half of the audience, that will give us a fairly good sample size to know where the audience falls relating to the questions. Okay. You don't have to think too much about the questions, just we shall be discussing the options at the end. Just, you can go with instinct. Okay, in about, I may probably close this poll in about a minute. So if you can respond as soon as possible, that would be great.
Questions have gone off before we submit it.
All right, a few seconds to the end of the poll, and then okay. All right. I think at this point I'll hand over back to I'll introduce the next speaker is Dr. Asima Kemigisha, who is going to talk about, is going to give a case presentation, and we shall listen and ask questions about the case at the end of the presentation. Thank you. Dr. Asima, over to you.
Good evening to you all. I'm presenting a 36-year-old female, NA. She was brought into the ED with a history of abdominal pain for about 7 hours and vomiting for 3 hours. She was a referrer from a clinic in Namugongo. Following an RTA, she was on a border heading to work when she fell off as the border was moving, and she hit her abdomen first. She claimed she did not lose any consciousness. She did not have any, she did not lose any consciousness. She did not have any seizures or reported bleeding from ear or nose. Her major issue was abdominal pain and vomiting. The referral clinic decided to, the clinic that she went to decided to refer her to Mulago. Primary survey, her C-spine was stabilized, was stabilized. Airway was patterned, her trachea was central, there was equal air entry. Notably, her respiratory rate was 24 cycles per minute, and her SATs were about 89 to 91% on room air. She had cool extremities, her capillary, she was cool up to about slightly below the elbow, and halfway between, below the elbow, and her capillary flow was greater than 3 seconds. Her pulse rate was 123 beats per minute. Her blood pressure was 80/32 with a mark of 49. She was pale, but we didn't see any active bleeding all over her body. Her GCS was 14/15, and her RBS at that time was 9.8. We exposed her. Her abdomen was tender, though there were no visible markings. Her pelvis was stable, and there were no fractures seen. And a log roll was done, and no Injuries were noted at the back. Impression was made of hypovolemic shock secondary to hemiperitoneum due to blunt chest trauma, blunt abdominal trauma. Sorry about that. Plan was to give her oxygen 5 liters and nosoprom. 2 large bore cannulas were placed. Ringer's lactate was 1 liter was given while we took off samples for CBC blood grouping and cross-matching, renal function tests and LFTs. An EFAS was requested for. We catheterized her, gave her 50 mics of fentanyl stat, and the plan was to transfuse her. And then IV tranexamic acid, 1 gram, was given. An EFAS was done that showed contusions on the inferior side of the liver with free fluid collection in the peritoneum. And this was the amount of fluid that we noticed. As CBC showed, neutrophil, total white blood cell count of 19 with a neutrophil of 17.0 and HB of 8.0, platelets 164. An ample history was done. No known allergies, no medications. She was not on any medication. She had no chronic illnesses, and she had had a cup of porridge 8 hours prior, and the events were the border accident while she was heading to work. Secondary survey, the only positive finding was generalized abdominal distension with tenderness, mostly around the right iliac and hypochondriac region. We reassessed her after the first resuscitation was done. Her airway was still patterned. She was breathing at 22 cycles per minute. Her SATs were 97% on 5 liters of oxygen. Her BP her blood pressure had improved to 102/82. Her pulse rate was 90, but she was with a regular pulse, but she was still pale. GCS was 15 out of 15. Her urine output was noted to be calculated about 0.8 units per kg per minute. General surgery was called to intervene. By the time they came in, they realized the patient was stable, so they decided we should do conservative management in the ED, monitor her vitals, give her paracetamol, IV morphine, continue with the ceftriaxone and metronidazole, a nil per os, and continue with the IV fluids at 500 mils for hourly, Ringer's lactate to D5. Day 2, her air was patent. However, now she was again tachypnic. She was 95% on 5 liters, so we decelerated the amount of oxygen we were giving her. Her blood pressures had gone down to 90/44. Her MAP was 59. Her pulse rate was 115. She was still pale. Her capillary flow was greater than 3 cool extremities. Though she was oriented in timeless and person, and her pupils were equally reacted in light to light. Her abdomen, you could see there was a change, the distension, and her urine output had dropped. So, as you can see from the previous EFAS findings, we noted that the fluid in the right upper quadrant and left lower quadrant and the right lower quadrant had increased, and so we assumed she's still bleeding. Her HB had come to about 6.4. Plan was to we gave her fluid as we waited for the blood to come. So we transfused her with 1 unit of blood as she was taken for an explorative laparotomy. Intra-op found a laceration with a hematoma on the right lobe, and they placed Surgisil to help stop with the bleeding. She was transfused with another unit of blood intra-op, and adrenaline was used to maintain her blood pressure. Post-op, she was stable. Patient was later disposed of to Ward 2A and discharged after 5 days. An improvement. That's the end of my guess.
Thank you very much. My apologies.
Right. Do you have any questions from the audience regarding the presentation? I think Dr. Simwe, I see a question here that says, thanks team for the presentation. Why was fentanyl administered at admission in the ER? Dr.
Patient had been at a private clinic that had provided her with IV paracetamol, and she was not, her pain control was not, her pain was not well controlled. So we gave her fentanyl as we were monitoring that patient. Yes.
Okay, I hope that answers that question. Another question from the chat is, why was exploratory laparotomy deferred in the first case, given the EFAST findings?
So when the surgeons came in, this one we had that we had stabilized the patient. The patient had markedly improved, so they thought that maybe a hematoma had been formed, and that maybe the bleeding would have stopped at that point. So they thought conservative management would be the best route for the patient at that time.
Okay, maybe a follow-up question is, was that the opinion of the entire team, or it was only the opinion of the surgeons?
Opinion of the surgeons.
So if it had been up to your team's decision, would you have gone in at that moment?
Yeah, we actually asked them to go in. But
okay.
The reason for our consult was for the patient to go in. However, when they came in, they thought otherwise, so we decided.
Okay, all right, thank you. And then I think there's another question here. Could it be, sorry, someone has asked, thanks, Dr. Simwe. Just wondering how patient scores 15 with those hemodynamics and EFAST findings worse than the first ones. Could it be because of earlier sympathetic drive? What are your thoughts? Why was your patient scoring full consciousness despite severe hemodynamic instability?
If you notice with the patient on the second day,
Hello, we can't hear you well.
The second day the patient had improved. I think we had managed to resuscitate them. We had resuscitated them, so they had improved. So maybe the fluid and the blood that had been given helped improve in the circulation to the brain. And that's why our GCS had improved.
Okay. Well, the other thing is also, how old was your patient?
36-year-old female.
36. Yeah, so usually young people tend to compensate pretty well for hemodynamic instability compared to older patients. So yes, indeed, it's possible that the sympathetic drive.
There are more guys from internal medicine.
Whoever is unmuted, please mute yourself and try not to interrupt the session. So young patients tend to be resilient regarding shock states, and so their consciousness doesn't really go unless it's extreme. The other question for you is, why give blood in a bleeding patient? Open tap phenomenon? Someone has asked that.
So at that point, when we decided to give blood, we assumed, because we had said now conservative management, we thought the patient had stopped bleeding. So that's why we gave the blood the very first day. That was the assumption we were going with.
All right. Okay, so, and also because you had the severe anemia, okay? Isn't that so?
Yes, that's right.
Okay. And then the other question here is, thank you, Dr. Simwe. What were the vitals intra-op that made you use adrenaline?
Unfortunately, I did not go intra-op and I didn't get that. However, I was not in theater with the team, but that was the report I got.
Maybe perhaps any reason why you think
Perhaps maybe their blood pressures dropped and they didn't have noradrenaline.
Okay.
They didn't have noradrenaline, so they went with adrenaline.
Yeah, I think sometimes adrenaline may be used because of the anesthetic's capacity to cause vasodilatation. So it could be along the line that maybe the patient was both hypovolemic and vasodilated because of the anesthetics. And so the team probably chose to do adrenaline to overcome the vasodilatation as well as give fluid. That information, Dr. Simwe doesn't have it. The question here is, was 1 liter enough for the ER initial resuscitation given the hemodynamic state? In how much time was it intended to run? Thanks, Doc.
So we gave 1 liter fast within 30 minutes, and that's when we decided to give the patient 1 minute of blood, and the patient stabilized at that point. So we put the patient on maintenance.
All right. So how did you, maybe the question here would be, how do you determine what is enough? Dr. Simwe, that's to you.
Estimated.
Yes.
Dr. Simwe, you're there?
Yes.
Yes, Dr. Simwe, go ahead.
So we're looking at the maps of the patient, and we're with the estimated blood loss that the patient, with the fluid that we calculated from the what we'd gotten from the EFAS. So we resuscitated with 1 liter, and when we saw our maps were improving, plus the when we saw a low HP, that's when we said that's when we decided to transfuse the patient.
Okay. I think considering that your hemodynamics improved, and I think you're also looking at your blood pressure and the patient's general clinical state in terms of perfusion, I think the determination of how much volume you give should be based on the targets met and not necessarily on the volume given. So I think that is what you are using to guide you in terms of resuscitation for this patient. And then there's a question here, and I'll take 2 more questions from the chat, and then we shall close it and go to the next presentation. How did you rule out blunt chest trauma and pelvic fracture?
I beg your pardon?
How did you rule out blunt chest trauma and pelvic fracture?
So from examination and also from a point of care ultrasound scan, point of care ultrasound, we ruled out any structural deviation from our examination, any rib fractures by palpating, emphysema, and then POCUS. And also chest X-ray was better done to show, and the findings were negative. For a blunt chest, for pelvic fracture, it was examination, our examination findings.
All right. Someone that's open tap concept. I think that is when you just basically open the taps into the patient. just pour fluid in and restore their blood volume as soon as possible. The final question here is, let me see. Okay, so someone asked about the anesthesia chart and why adrenaline. The final question is, was ruptured spleen excluded intra-op?
Yes, it was.
All right. Okay. Thank you so much for this presentation. And I think I would ask you to summarize for us what problems existed in this patient and what was the cause of those problems. And then we shall move into the next presentation. Dr. Asimwe, a summary of the problems you had in your patient and what you think the cause was, or what the cause was, and then we move to the next presentation.
Summary. So the patient basically had blunt abdominal trauma and had hemiperitoneum secondary to a liver laceration in the right lower lobe that caused the patient to lose a significant amount of fluid that caused them to go into hypovolemic shock.
Oh, okay. Thank you very much. The hypovolemic shock here is the hemorrhagic shock. All right. Dr. Orikuza Joshua is a year 3 resident in anesthesia and critical care at Makerere, and he's going to talk about endothelial glycocalyx and the revised Starling principle. If you've already done the quiz, perhaps your answers are going to come at this point. So Dr. Joshua, please take it away.
Good evening. I am Joshua Richiriza, as I've said, and I'm resident here 3. I'm going to be talking about the endothelial glycocalyx and the revised Starling principle. So the outline of what we're going to look at the classical Starling principle. We look at the modifications and further work that was done on the classical Starling principle. Look at the endothelial glycocalyx and its structure, and also we shall discuss the revised Starling principle and its application in clinical work. So in 1896, Starling, through various experiments, concluded that there was filtration happening at the arteriolar end and absorption happening at the venular end of capillaries, and he concluded that this was due to differences in colloid osmotic pressure, but also hydrostatic pressure along the capillary. This original Starling principle has had further modifications and criticisms from microvascular physiologists and intensivists. And as we see, that's how we come up with the revised Starling principle. So according to the original Starling principle, at the arteriolar end, the hydrostatic pressure was greater than the colloid osmotic pressure, and we had filtration happening. And then at the venular end, the oncotic pressure was greater than the hydrostatic pressure, and we had absorption happening. But now we know that is not what happens. So frame A shows what the original Starling principle postulated, but frame B shows what we know right now, that actually filtration occurs along the whole length of the capillary, though it's more at the arteriolar end because of the higher hydrostatic pressure, but it occurs along the whole length of the capillary. And then frame C shows us what happens. We shall talk about it in a minute. So I don't know. I'm not having any other device unmuted here. I don't know why I'm having feedback.
It has been fixed. Go ahead. So
after Starling's work, William Bayliss, during the Great War, he treated soldiers that had been shot and been wounded and had bled a lot, and they were hypovolemic. So they had low BPs, treated them and divided them into arms. One arm received crystalloid and the other arm received acacia gum. And from his findings, they were published that the arm that received crystalloid got significant improvement in BPs compared to the arm that received crystalloid alone. The arm of the acacia gum got significant increase in BPs, but it was later on found that acacia gum contained calcium and through its action on the smooth muscle, it caused the increase in BP. So the Starling principle was still questioned at that point. We still question it reading the findings of William Bayliss. Also, Starling later on went on to do further work and realized that the interstitium actually contained plasma proteins, which we now know that the glycocalyx has some gaps through which the plasma proteins leak. And so there was no Starling equilibrium as it had first earlier on been said. So Landis, a student, also was a medical student. He did start work that was in agreement with Starling's work. But Michel and Philip in 1987 did something through their work also. They found out that capillaries at low blood pressure absorb fluid transiently, but not in steady state. And I think that was the turning point where the microvascular physiologists started thinking about what happens actually at the capillary level. So when capillary pressures are dropped suddenly or acutely below 20, the norm is between 15 to 20, but let's take 20 as our normal now. If they drop below, then they are acutely, there will be a transient period of reabsorption. That's what Michel and Philip were able to find out. And then after steady state has been achieved again, the reabsorption stops and filtration occurs again. So reabsorption occurs transiently. Levick in 1991 also agreed with what Michel and Philip had found. So the endothelial glycocalyx. The endothelial glycocalyx is a protective gel-like layer covering the endothelium of capillaries. It is dynamic and complex. Its structure is complex. It keeps on changing with time, with different situations. It keeps on changing the structure of the glycocalyx. It has three main components. As you look at the diagram, the glycoproteins, which anchor the glycocalyx to the endothelium. It also has proteoglycans, which are the core molecules of the glycocalyx, and then the glycosaminoglycans, which really are in plasma mainly. They are the ones in contact with plasma. It also has other components, the antithrombin 3, superoxide dismutase, chemokines, and growth factors. We shall see the use of all those components of glycocalyx as we go on in our discussion. On an electron microscope, that's how the glycocalyx would look. It has a brush border end, and these are our glycosaminoglycans, and the endothelium is here. And here, the subendogycocalyx space is also very significant for our discussion. This space is almost protein-free. And as we shall know, in the revised Starling principle, the osmotic pressure gradient is not between the plasma and the interstitium, but it is between plasma and the subendogycocalyx space, this space here, which is almost protein-free, and the plasma contains protein. So this is a very significant space for our discussion. That is just another diagram to emphasize what you've said. So what are the functions of this of the glycocalyx? It controls the blood cell and vessel wall interaction. We've said the glycosaminoglycans are negatively charged, and they repair red blood cells. When you look at movement of blood through a capillary under a microscope, you would think that a red blood cell wouldn't go through the smallest capillaries, but it still goes through. How this happens is by the work of the glycocalyx. Also, the adhesion molecules of the endothelium are covered by the glycocalyx. So the leukocytes and the platelets that would adhere to the endothelium keep on moving within plasma, because they are of the work of the glycocalyx covering the adhesion molecules. It's the determinant of vascular permeability. It has glycoproteins that participate in the coagulation pathway, and it controls the microenvironment in the vessel through its the enzymes, the antithrombin 3, the chemokines, and all other components. It controls the microvascular environment. So the revised Starling principle. The first 2 points talk about the original Starling principle and what we knew, that what was known then, that filtration happens at the arteriolar end and reabsorption happens at the venular end. But now we know that that is not true. We know that plasma proteins are anchored in the glycocalyx, on the glycocalyx, and fluid movement is determined by the pressure gradient between the plasma and the subendogalactocalic space, mainly. Plasma and this space here, the subendogalactocalic space, not plasma and the interstitium, as it was previously. The interstitium has a minimal role to play, but the movement, fluid movement across the endothelium is mainly by the plasma, which is protein-rich, and the subendogalactocalic space, which is almost protein-free. So, what I've just said, the effect of the interstitial oncotic pressure is really minimal and can be negligible. We also know now that filtration happens along the whole course of the capillary, though it's more at the arterial end compared to the venular end, but it happens along the whole length. Reabsorption does not occur except in states of acute disequilibrium or acute hypovolemia. That's when we get reabsorption occurring. And this fluid that has been filtered, if you follow the diagram, the major route of its return to circulation, to systemic circulation, is through the lymph. So the fluid is filtered, the afferent lymphatic carries it to the lymph node. The capillaries of the lymph node are special. They can do reabsorption. There are a few capillaries in the body, in the kidney, in the lymph nodes that can do reabsorption, and even in the liver. So the half of the fluid is reabsorbed by the capillaries of the lymph node, and then half of it is transferred by the efferent to join through the efferent lymphatic to join the thoracic duct, and then back into systemic circulation. So fluid that is filtered, unless in acute hypovolemic states, is not reabsorbed, but goes through the lymphatics back to systemic circulation. So when we give plasma, when we give colloid, and what we've been knowing that when you give colloid, you're increasing your oncotic pressure of plasma, and then you're going to reabsorb fluid from the interstitium. This does not happen. That's what the first point is explaining there. And we look at this graph, what I've already explained from the work of Michel and Philip, that reabsorption only occurs transiently in the acute hypovolemic states or acute disequilibrium, but when the steady state is regained, reabsorption stops. And also that reabsorption is limited to about 30 minutes and can only give us about 500 mils of reabsorption of fluid in those acute hypovolemic states. So that's what I've just explained. The autotransfusion, that acute period of reabsorption can only give us about 500 mils of fluid. So this was just summarize the differences between the classical and the revised or extended Starling principle. So how are these applied in our daily practice? In hypovolemia, in hypervolemia, in leaky capillaries, and how our vasopressors work. So in hypovolemia, we have low hydrostatic blood pressure, but this will also be hydrostatic capillary pressure. This, on the y-axis, we have filtration. On the x-axis is capillary pressure, hydrostatic capillary pressure. So in hypovolemia, we have low hydrostatic capillary pressure because of the low volume, but also the compensatory vasoconstriction will further lessen the hydrostatic pressure. So when you give fluid to a patient who is hypovolemic, all the fluid you give, if they're still hypovolemic, it will stay intravascular. No filtration will be happening along this point until when we reach our normal, which is 15 to 20 of capillary hydrostatic pressure, and then filtration will begin to occur. So what we've always known that when you give fluid, either saline or Hartmann or whatever you give, and then a third of it stays intravascular and 2/3 of it goes to the interstitium, is not true. In hypovolemia, the fluid you give the patient stays in the intravascular compartment until you reach a filtering hydrostatic capillary pressure. In hypervolemia, what happens? So mainly one thing I did mention is of the total albumin, of the total body albumin that we have, 40% of it is in plasma and 60% of it is in the interstitium. So in hypervolemia, what happens when you give fluid to a patient that is hypervolemic already, or that is normovolemic, and then you're pushing them to hypervolemia? What happens is there will be increased filtration, and this albumin that has been in the interstitium will be washed away and carried away by the lymphatics, and then the osmotic pressure gradient will increase, and then we have more filtration and more filtration happening. So in hypovolemia, when you continue giving the patient fluid, you're going to cause actually edema. That's what I would say for a simple understanding. Leaky capillaries, like in sepsis and in other inflammatory conditions. So what happens in sepsis? The endothelial glycocalyx is destroyed, the endothelium becomes leaky. And so when you're giving fluid to a septic patient, the endothelium is already leaky. So you're losing even the plasma protein that was there is also washed away. And so you almost only be dependent on hydrostatic pressure, not on the osmotic pressure difference between the compartments. And for any small increase in hydrostatic pressure, you will get more above the J point. This is above this J point. For any small increase, you will have more filtration happening. Vasopressors, what they do, they try to reduce reading capillary hydrostatic pressure and vasopressor, how they relate. But what happens, let me just say it, vasopressors reduce capillary hydrostatic pressure. And they try to take it back to the so from here, from our septic patient with the leaky capillaries, with the curve shifted to the left, the vasopressors will try to reduce the hydrostatic pressure and bring it back to normal values and try to mimic the normal state. That's what our vasopressors will do. Hope it makes sense. So there are things that happen and destroy and damage the glycocalyx, hyperglycemia, smoking, and hyperlipidemia. Those are things we usually encounter. But what I wanted, maybe for our fluid management, hypervolemia has been shown to damage the glycocalyx. Also, hypovolemia has been shown to damage the glycocalyx. Inflammatory states with cytokine release and enzymatic degradation, ischemic reperfusion injury with release of ANP from the right heart also has been shown to damage the glycocalyx, and also major vascular surgery going above 6 hours has been shown to damage the glycocalyx. This will just show us a normal glycocalyx and a damaged glycocalyx. So I've already said this, sepsis, inflammation leading to destroying the glycocalyx, impermeability of the endothelium increasing, causing leakage of plasma, interstitial edema, and hypovolemia, and tissue damage and organ damage. Also, since the glycocalyx is destroyed in sepsis, we shall have the adhesion molecules of the endothelium exposed, and we shall have leukocyte and platelet adhesion, leading to a state of DIC. So when the glycocalyx is damaged, this is what may happen. Endothelial permeability is increased, platelet aggregation, endothelial, what I've just said, endothelial leukocyte adhesion and inflammation, and then hypercoagulability. That's what the consequences of our damaged glycocalyx. So protection of the glycocalyx. These are some of the things that have been shown to protect the glycocalyx. But of all this, I think normovolemia is what is, because albumin has been shown to be detrimental. Studies have been done to show that albumin can actually be detrimental in a patient. The CRASH study has shown, I think CRASH 1, CRASH 2, hydrocortisone can also be detrimental. So what really we can do and what is within our means is to target normovolemia for a patient that if we think we're going to protect the glycocalyx. Normovolemia is what is within our reach and what I think we can all do to our patients. So when the glycocalyx is damaged, I don't think we do this here, but those molecules that make up the glycocalyx, the glycosaminoglycans and the glycoproteins can be checked in plasma, and their levels can tell us the extent to which the glycocalyx has been damaged. I don't think that is done here. So in conclusion, William Hunter in 1675, around there, made this statement that I have proved that the lymphatic vessels are the absorbing vessels all over the body. These, together with the thoracic duct, are dispersed throughout the body for absorption. This statement was made almost more than 300 years ago, but now Stirling came up along the way and work has been done up to date. But now I think William Hunter is true. We can still hold this statement true up to this day, though along the way we may have lost it, but I think it is true up to this day. So in conclusion, these are words of Thomas Woodcock, famous gentleman who has done work on the glycocalyx, who has raised the argument and the discussion about the glycocalyx. In his word, he says, keep calm and just say no to colloid osmotic pressure support. You can give colloid to treat any other thing, but don't give colloid to increase the osmotic pressure support, to treat edema, with the aim in mind that you're going to absorb fluid from the interstitium back into the intravascular space. That won't work. Thank you. I hope I'm within time. Thank you.
All right. Thank you, Dr. Joshua. All right. So do we have any questions from the audience? You can post them in the chat. Otherwise, as we wait on the questions, Dr. Joshua, I will share the results of the previous poll, and we can discuss them for the next approximately 10 minutes. Hopefully we'll be done by then. And if there are no questions in the chat, then maybe this will suffice. So in a normal healthy adult, the intravascular half-life of isotonic crystalloid is approximately, so a majority of the audience picked 30 minutes, 43%, and actually that is true. The half-life for crystalloids, isotonic crystalloids, is about 30 minutes. And then in a normal healthy adult, intravascular half-life for colloids is approximately 57% selected 2 to 4 hours, which is also true, but this is in normal healthy patients. And like Dr. Joshua has talked about the glycocalyx, if it's damaged, then the half-life is much shorter than it is in healthy patients. And then the blood volume, for blood volume expansion, colloid to crystalloid ratio is approximately, so a big part of the audience chose 1 to 2. Joshua, thoughts on what ratio is more consistent with data?
Dr. Kudel, I'm not seeing the poll question.
Oh, you're not saying, go to your polls and quizzes. I don't know if the rest of the audience is able to see the poll questions, but you can go to your polls and quizzes and click that. You should be able to see it. Are you able to see it?
I'm seeing the first poll question only.
You can scroll down.
Yes, sir. Just scroll. You can scroll. You'll see the rest.
Question number 3, volume expansion. Yeah. So colloid to crystalloid ratio approximately 1 to 1, 1 to 1.5, 1 to 2, 1 to 3.
So I would go with option. I'd go with the second option, 1 to 1.5.
Yeah, so it is based on current data, it seems to be around the 1.3, 1 to 1.2, 1 to 1.5, somewhere approximately that. So the old Frank Starling principle seemed to suggest it was 1 to 3 with the idea that you have reabsorption. Okay, and then regarding fluid shifts, which of the following is false? Dr. Joshua, I think you have talked about this. Fluid isn't reabsorbed back into the capillary by oncotic pressure, and I think you've mentioned that. That is not, that is true actually. It's not reabsorbed. It actually goes through to the lymphatics, which covers the second option, which is also true. And then oncotic pressures in the interstitial space are higher than originally thought. Again, I think you mentioned that. And then the administration of albumin increases fluid reabsorption from the interstitial space. Joshua, the comments on that?
That is false.
That is false. So that again, reabsorption is not a frequent occurrence. It's only under very few circumstances, especially with the low hydrostatic pressures. And that is not normal. Then regarding
Dr. Connell,
yes,
we can't see the poll. We can see the slide, but not the poll.
So the poll, if you can't see the poll, please go, if you're using your phone, even if the slides are not shared, if you're using your phone, go to the 3 dots on the lower right corner of your screen, tap that, and then it will bring up the options of polls and quizzes. Tap that and you'll see the poll. If you're using a laptop, you can go to the button that has polls and quizzes, and you click that and you'll see the polls, and you can scroll. There are about 6 questions there, and you can follow along. And then number 5 is regarding the glycocalyx.
It doesn't have the option, but it's okay, you can carry on.
Let me try and share again, sorry. Can you see the polls now? You should be able to see them now. Okay, so regarding the endothelial glycocalyx, which of the following is false? So Dr. Joshua, is it a physical barrier only?
No, I don't think it's only physical, because no, it's not only physical. I don't know how I can say it.
It's also an electrical barrier, isn't it?
Yes, electrical, biochemical.
So it has a fairly, I think it has a negative charge that repels most of the protein, then keeps them on the other side of the barrier, and that's why you have the sub-endoglycocalyx layer, almost devoid of all proteins. And then here it says it creates an oncotic gradient within the vascular system. Is that true or false?
So it creates within the vascular system, yes, I would say, because it creates the subendoglycocalyx space is within the capillary. So it creates the oncotic pressure gradient within the vascular system.
Yeah, so it's within the vascular system, contrary to the original Frank Starling. And then it's least found in the liver, spleen, and the bone marrow, basically the reticular endothelial system. Is that true or false? I
would say it's true, because capillaries in those areas, I think, are fenestrated and can do reabsorption. I don't know if I'm right.
Yeah, so there's a lot of ultrafiltration within, especially the liver, and that's because of the massively fenestrated capillaries in there. And then you mentioned it's a determinant of vascular permeability. Final question is the following can damage the endothelial glycocalyx. Any of these major prolonged surgery, what are your thoughts on that?
Yes, major prolonged surgery for about more than 6 hours has been shown to damage the glycocalyx.
You mentioned sepsis. What about major trauma and polytrauma?
I've not come across that, but I think if surgery does it, I think also major trauma would do it.
I think it should be more along the lines of the pathophysiology, isn't it?
Yes.
Similar to what you'd have in a systemic inflammatory response syndrome.
Yes.
Okay, and then would albumin infusion damage the glycocalyx?
So albumin infusion theoretically would be thought about as protective to the glycocalyx, but studies have shown that there is no, I don't know I can say it, but theoretically it would protect the glycocalyx.
Okay, so theoretically, yes, there could be some benefits with albumin, and maybe Dr. Timothy will tell us more about that. Whether those benefits are actually real or they are largely imagined, we are not sure, but what we are sure of, it's not one of the major things that will damage the glycocalyx. All right, so that brings us to the end of the discussion for that. I will immediately launch the next poll and request Dr. Peter Waswa to prepare his slides as we to present his slides as we do the next poll. So Dr. Peter Waswa is, I think he's currently a newly graduated anesthesiologist and also a critical care medicine fellow with a SCALE program, and will soon get his training done and completed. But he's going to talk to us about fluid therapy and what is called the ROSE protocol. As it sets up, I will launch the next poll. Has 6 questions, and in those 6 questions, we have the first one talking about which of the following is false regarding fluid therapy in the ICU. and select whatever answer you think is correct. Only one answer for number one is considered to be correct. In this case, considered to be false. And then the second question is about fluid therapy. Again, what is false? Is hypovolemia worse than hypovolemia? Resuscitation fluids are the least amount of fluids we may give. What about maintenance fluids? If you're not sure, you can always click I'm here to learn. That is also acceptable. We are all here to learn. And then regarding fluid creep, select what is true. Again, if you have no idea what fluid creep is, it's okay. We shall learn what that is. And then hypotonic fluids result into the least cumulative fluid balance. True or false for that one. And then number 5 is about colloid therapy and what is false. Talking about albumin colloids. And yes, Fred?
I don't know if it's just me, but I'm not seeing the polls. I saw the first one, but not the subsequent one.
Have you gone to the, are you using your phone or laptop?
Phone, but that option is not there.
There are 3 buttons that on the right lower side of the phone. Tap that.
There is no option for polls. I think because of the slide, maybe.
No, the slide shouldn't interfere. Is anyone else, if there's anyone else experiencing that problem, please post in the chat. I can see about 13% of the audience has responded, and I'll probably close the poll in the next about 3 minutes. So if you can get to it. Anyone else having the same problem, please post in the chat and we'll see what we can do on this side. Fred, have you managed to sort out the issue?
No luck, but I think when the slides come up, I think it gets distorted.
All right, in the next 30 seconds, I've seen we are almost 50% of the audience, and I will be closing the poll. If you are listening in from YouTube, feel free to ask questions in the chat on YouTube. I'll be able to see them and ask the presenter. In the next 10 seconds, I'll close the poll. I can see some are still answering. So if you have been able to answer, please make sure you answer quickly because I'm going to close the poll in a few seconds from now. Okay, I'll close the poll now. For those who have not been able to launch the poll, we shall try to prevent the slide sharing next time and see if that helps. All right, Dr. Peter Waswa Omurongo, please go ahead and start your presentation.
Thank you, Dr. Cornelius, for the introduction. Can you guys hear me?
Loud and clear.
Yeah. So I'm going to be taking us through fluid therapy and the ICU. I'll talk about the ROSE protocol and then something more about the ROSE protocol. So to note, IV fluid therapy is one of the commonest interventions that we do to our patients that are acutely ill. And it was found that actually 20% of patients in the ICU receive IV fluid resuscitation within, and of those, 30% receive these fluids on their first day in the ICU. So for us to talk about fluid therapy, there are terms that we need to be well versed with. One, that's fluid balance. So traditionally, fluid balance is fluid balance is done every day when a patient is in the unit. Every day, so idea is supposed to be done every hour when you keep on balancing your inputs and outputs. It can be positive, can be negative, it can be zero. And then expect you to be doing your fluid balances every 24 hours. And then each and every day, attending to your patient. So fluid overload has been known to be traditionally, like if you admit a patient with a weight of say 60 kgs at the point of admission, and then 10 days later, okay, maybe after some few days in the unit, when you do your cumulative fluid balance, and then you divide it with their weight times 100, and you get a value above 10%, that has been taken to be fluid overload. However, you're not supposed to see patients in isolation. So beyond the value of 10%, we expect you to also assess for other clinical parameters that are going to be indicating to you that your patient is fluid overloaded. Things like patients having pulmonary edema, having new onset of pitting edema, someone might be actually having an ASAPA. So that takes us to goal-directed fluid therapy, whereby I used removal because a mistake, whereby you'd want to give your patient fluids tailored to that individual patient. In the sense of not giving too much and not giving too little. As we guide with the slides, we shall know at what stage we start fluid removal. So to note, fluids are drugs. I'm sure I don't have to take a lot of my time convincing this audience that actually fluids are drugs. So because fluids are drugs, we're supposed to treat them as drugs. What does that mean? You're supposed to give your individual patient the right dose of fluid. You're supposed to give them that fluid for the right duration. And then you're supposed to begin to know when actually to stop giving the fluids. So that means you're supposed to answer both 4 questions when you're giving patients fluids. You're supposed to know when to start giving your patients fluids. You're supposed to know when to stop. You're supposed to know when to start removing and also when to stop removing because you've given too much and you've actually achieved your target. So these questions are always going to be guided by your clinical assessment, the presentation of your patient. So there are about 3 reasons why we give patients fluids in the ICU. And each of us is going to have an interaction with a patient at a different stage or all the 3 stages. So sometimes you want to receive a patient who has a perfusion deficit, and then you want to resuscitate them so that you restore the perfusion. Then another person actually interact with this patient after resuscitation has been done, but you want to maintain the state of perfusion by giving the patient actually what they need. So, and then also we give patients fluids in terms of nutrition through the gastric tubes, and also those that get medications, IV nutrition through the intravenous lines. So we also give patients replacement fluids. So the goal for giving patients replacement fluids is to basically replace what they've lost. And then maybe to note on maintenance, if giving a patient a maintenance fluid, the goal is to replace what they need for their normal requirements. Things like glucose, potassium, sodium. So we have about three kinds of fluids that we are going to be giving our patients in the ICU. But the common ones known to most of us are crystalloids and colloids. So when we talk about crystalloids, we're talking about things like normal saline, then lactated ringers, and then colloids, things like albumin, blood products, such as, and we're going to be giving them these patients as indicated. So when we are giving patients IV fluids, our target is to achieve normovolemia. Why? Hypovolemia. So when you look at the image, the graph described, let me first get a pointer.
Peter, go to the pen. Go to the pen there. The pen on your left, on the left side there.
Thank you, Dr. Cornelius. So this is a graph showing us volume status versus mortality. So you can see that within limits of normovolemia, we are having a reduction in mortality. So as you shift to hypovolemia, you're having an increase in mortality, and the same applies when you're moving to hypervolemia. So what does this mean to our practice? Hypovolemia, hypervolemia are both actually associated with worse outcomes and mortality in our patients. So when you overload a patient with a given fluid, it is going to have systemic effects that are going to be manifested in almost all the systems. This is just an image trying to show some of the things that are going to happen in case our patients have been overloaded. So, because reduced fluids are drugs, we expect you to know when to stop fluids, when they can no longer needed, and have your patients take orally. Why? Because when they take orally, the body is actually going to be able to select what it needs, and then it's going to eliminate whatever it doesn't need. So this brings us to the ROSA model, which was coined by a gentleman called Vincent and his colleagues. So it's just an acronym for resuscitation, optimization, stabilization, and evacuation. So these are things we expect you to do to a patient, depending on the stage at which you're going to talk to the patient. So within the few minutes of interaction with a patient who is having a perfusion deficits, we expect you to resuscitate them. So during resuscitation, we're actually giving a patient a given volume for you to restore a given flow. So you're not minding about, quite often you don't mind about how much or how fast. Once you've achieved, once you've at the stage of resuscitation, we'd actually want to optimize the patient. In other words, we want to keep the patient within the acceptable limits so that what you've actually corrected can be attained. And then, with days of staying with your patient, you want to reach a stage when you're going to be eliminating whatever excess that the patient is having, so that actually they remain within the state of your interest. So the acute dialysis quality initiative came up with also a different model of approaching a patient. And for them, they coined SOSD, whereby you're going to be having goals in each of these steps. After assessing hemodynamic stability of a patient, so the patient is actually in circulatory shock, you want to assess and treat the cause of instability. So you're going to do RACE, stands for Rapid Assessment Cardiac Echo. So you want to see the status of your patient by using cardiac echo. So you target a map about 60 to 65. once it has been achieved, then they give patients crystalloids, give them, and then they also recommend for early initiation of inotropes. So once that has been achieved, in the optimization phase, your goal is to improve organ perfusion, which you're going to be using clinical parameters to assess. So, and your targets are going to be maps above 65, cardiac index, urine output, and then normal serum lactate. And then in the stabilization phase, it's almost the same objectives for optimization phase, but you also want to offer organ support because the patient actually needs to be supported, and also initiate feeding. Once your patient has gone through these phases, now you want to escalate, which means you want to maintain parameters that have been achieved during the stabilization, and you want to normalize the patient's age status. So this brings us to a very important word of fluid stewardship. So we as health workers, we need to promote fluid stewardship, which means we're supposed to have a series of coordinated interventions which are going to be enabling us to select optimal fluids at the right dosage and for the right duration in order for us to get best clinical outcomes in our patient and prevent adverse outcomes, thus reducing the cost of care for our patients. So this is just a summary of introduction for fluid stewardship. Thank you for your attention.
Thank you, Dr. Peter Aswa. So with that, I think we'll ask some questions. If there are no questions, we can go to the poll question. There's a question on YouTube. YouTubers, we can see you. Is there any way to make the content? Oh, sorry, that's not for you. Sorry, that is for me. There is unfortunately no way to make it any clearer. Maybe YouTube is. All right. If you have any question, please raise your hand and then you will be allowed. Titus, are you asking a question?
What?
Are you asking a question? Okay, Titus is not with us. All right. So I'm going to share the results of the previous poll. Yes, Fred?
Hi, thanks, Dr. Peter, for the presentation. I would like to know, and maybe there is no particularly correct answer, but I'd like to know from research what's the kind of volume that patients will require in those minutes during the resuscitate in the rows, like an average.
Dr. Peter Aswa, that question goes to you.
When it comes to the, so thanks for the question, Dr. Lamba. Now about the average volume you're going to give a patient during resuscitation, I think it goes back to individualized care. It's not, I'm sure you don't have the answer for the volume for a given patient, because even what was suggested by the Surviving Sepsis campaign, the 30 mils per kg has just actually been known to adopt, because in some patients, it's actually a big volume, in others, it's a small volume. So I think it's about individualizing care. Give your patient a given volume as you're having clinical endpoints. You keep on assessing. Is the patient still needing to be resuscitated, or the patient has actually moved from the resuscitation stage to the optimization stage?
All right. Thank you for those comments. I think the important thing is not how much volume. The important thing is what are the targets you're trying to meet, and that will determine how much volume you're going to give. But also the idea here is if you find yourself stretching too much into giving volume and you're not having restoration of blood pressure, then you have to start to consider the use of inotropes and vasopressors. but most times the resuscitation, at least a fluid bolus. I don't know, Peter, also I think you defined what a fluid bolus is, yes?
I didn't define it.
Yeah, so usually a fluid bolus will at least in adults, will go for about 500 mils in a period of 30 minutes. It can go higher than 500 mils, but anything 500 mils and above may be considered a fluid bolus. But that is really to rapidly restore blood volume, like in the patient that was presented earlier. So if we go into the quiz questions for you, Peter, also for discussion, we have about 10 minutes for this, approximately. So the first poll question, I hope you can all see this. If you can't see this, please go, if you're using a laptop, go to the polls and quizzes button and click that. If you're using a phone, there are 3 dots on the right lower corner of your screen. You should be able to tap those and see polls and quizzes. If you can't see that, then possibly your Zoom may need updating. So which of the following, the first question is which of the following is false regarding fluid therapy in the ICU? I think Dr. Erasmus opened this session by saying fluid administration is the commonest fluid therapy. So that is true. And then fluids are drugs. I think Dr. Peter Aswa has mentioned that, and we should prescribe them just like we do antibiotics. And then edematous patients can be hypovolemic. Dr. Peter Aswa, your take on that?
Yes, that is true. Some edematous patients can actually be hypovolemic.
All right. And so that is true. Are colloids superior to crystalloids in volume expansion?
From the previous discussion by Dr. Joshua, we've actually learned that the superiority of colloid to crystalloids is actually going to depend on the stage of resuscitation, on the stage the patient presents in. So they are not superior to crystalloids in volume expansion.
All right. So no difference, not much difference between them. I think we can move on to the next question. Okay, the next question is about regarding fluid therapy, which of the following is false? I think your slide clearly mentioned that hypovolemia is terrible, hypovolemia is worse. And then resuscitation fluids are the least amount of fluids administered in critical illness. Dr. Peter, also thoughts?
Yes, from studies that have been done, actually resuscitation fluids are found to be contributing about 6%.
Okay, that is true. And then maintenance fluid is the highest amount of fluid administered in critical illness. Is that true or false?
That is not true. Instead, what has been found out is that actually it's usually nutrition and then fluids for resuscitating patients with burns.
Okay. So it seems the maintenance fluids also includes nutrition in this case, because nutrition also covers the amount of fluid that is required daily. So it constitutes the first amount of actual fluids that you're going to give to the patient. The important thing is to remember that you can use IV route or you can use enteral route. But as soon as the patient doesn't need IV, in most instances that will be beyond 48 hours for the patient you've been resuscitating, odds are they don't need IV maintenance. You need to switch them as soon as possible to enteral nutrition to allow them to sustain their own basic requirements. And then, Dr. Peter, so this one is also for you. The body is more adapted to handle hypervolemia than hypovolemia. Is that true?
I'm not certain about that, but what I may say is it depends on how fast you're making the patient hypervolemic or how fast the patient is becoming hypovolemic.
Okay, so naturally, our bodies are adapted. The kidneys, for example, will adapt themselves. If you have a situation of hypovolemia, they will activate the RAS, and then you'll be able to retain fluid. But naturally, our bodies do not have the adaptation to handle too much fluid. And so the kidneys are not going to all of a sudden start to release so much of the urine just because you're hypervolemic. So once you start to overload the patient, the response is not as fast as we think it will be compared to hypovolemia. So it is important. That's what makes hypervolemia worse than hypovolemia, because the adaptability to dryness. For example, you have people staying in the desert and they are fine, and they live on very little fluid. So such scenarios are allowed because of the adaptation of the human body. So hypovolemia is actually better handled by the human body than hypervolemia. And then, so the third question is, which of the following is true regarding fluids? Fluid creep. Maybe Dr. Peter, also you can tell us what fluid creep is.
So fluid creep is actually a term that's used in patients that are resuscitated following burns. What happens is there are standard formulas that we have for resuscitating patients with burns. But sometimes what happens is patients actually can end up requiring actually more than what they should receive as per the formulas that were stated, things like the Parkland formula.
Okay, so fluid creep is actually not a maintenance volume per se. And it's also important to know that it only contributes approximately a third of the volume administered and not 2/3. And it is actually the volume that we usually give when we are giving drugs and flashes, saline flashes for drugs. And we don't usually factor in that amount of fluid, but over days, that fluid actually leads to a fluid balance. So if you have a critically ill patient, you have to be very wary of extra volumes that occasionally may not be factored in calculation or in estimation of the fluid balance. And those extra volumes can actually lead to a cumulative positive fluid balance, which we know is associated with poor outcomes. And then number 4, hypotonic fluids are result in less positive cumulative fluid balance. Dr. Peter Waswa, thoughts?
Less positive fluid balances.
Yes. Is that true or false?
I think it's, but I'm not sure.
So the current data suggests hypotonic fluid, especially in adults, not in pediatrics, leads to the least positive fluid balance. And that means if you're going to use IV maintenance fluids for any reason, you probably want to avoid too much sodium, and because sodium drags water along with it. So you want to avoid too much sodium, and isotonic crystalloids tend to have a huge amount of sodium in them, and over days, if you're using it as maintenance, may actually lead you to get a more positive balance. So it is actually true that hypotonic fluids cause the least amount as maintenance fluids, not as resuscitation fluids. You don't want to use them for resuscitation, they're terrible. And then regarding colloid therapy, which of the following is false? Albumin is contraindicated in TBI patients. Is that true or false?
It's false.
So it's false. Well, I think we shall hear from Timothy and see what he says, since we're going to talk about albumin. And then synthetic colloids are contraindicated in septic shock. Is that true or false?
They are not contraindicated, but they are not the best for patients in septic shock.
Would you give a patient with septic shock, let's say, a starch solution?
I wouldn't give them a starch solution because it is not going to sort their problem.
Okay, so most of the current data seems to suggest injury to the kidneys with synthetic colloids, and so most of the guidelines at the moment would say not to use them, especially in septic shock. But I think we shall have that discussion later on. In the patient that we had in this case, it was hemorrhagic hypovolemic shock. And I think Dr. Peter Waswa and Dr. Asimwe Kemigisha, I would like you to respond to the use of colloids in hemorrhagic shock. Should we use colloids, synthetic colloids?
So if a patient has hemorrhagic shock, their issue is they've actually lost the blood volume. So the best thing is to give them what they've lost and then add on a crystalloid. So giving them a synthetic colloid is not going to restore their blood volume, though it is good, part of it is going to have a small contribution to your blood volume. Let's see a competition.
Dr. Asimwe, thoughts? Could you have used a colloid to restore blood volume in that patient? Would that be a problem?
Yes, Dr. Connell, I wouldn't have used, I think fluid and blood was enough for this patient, for my patient. I don't think it would be necessary for me to use a synthetic colloid.
Yeah, and I think we've already established that the ratio is 1 to 1.5. So crystalloids would potentially do that for you. They're cheap. They do this. They almost achieve the same outcome in terms of restoration of blood volume, despite colloids probably spending more time in the intravascular space. Although the military, at least the advanced militaries, may tend to use colloids for rapid volume expansion for patients injured in the field, crystalloids can still get the job done as far as we know at this point. So the use of colloid is gradually being phased out because of they are not being so different from crystalloids in terms of volume expansion. But we shall hear from Timothy again, since he's going to talk about albumin too. Final question is: there's limited role for IV fluid in the majority of critically ill patients beyond 24 to 48 hours. Dr. Peter Waswa, comments. Is there limited role of
Yes, there is. Reason is within the first 24 to 48 hours, we expect the patient to have been resuscitated well. So we are now in a phase of optimizing and stabilizing the patient. So within that time, most of the deficits have been sorted. So we are basically just trying to keep what has been established.
All right. So in a majority of patients, that is true. Very few patients will require IV maintenance fluid beyond even 24 hours. Again, the principle is as soon as the patient doesn't need the volume, the IV fluids, which in most cases is for volume expansion, you need to switch them to maintenance, which in most instances, enteral intake or input would suffice. All right. So thank you for responding to those questions. I'm going to look at the chat to see if there are any questions. Dr. Joshua, a question for you: effect of dextrans on the glycocalyx?
I've forgotten.
Is there any effect of dextrans on the glycocalyx? That is what the question is.
So people who are, what in my reading, what I came across is, I don't think they have an effect on the glycocalyx.
All right. So I think we shall leave it at that and see what the end of this conversation, of this discussion will yield. In the meantime, I'm going to launch the final poll, and this is going to be about the last topic on albumin and physiology. And here it is. If there are any questions in the chat, they will be answered after the next speaker. So I'm going to stop sharing the slides and invite Dr. Timothy Moyembo, who is an anesthesiologist and an intensivist. And he is also a captain in the military. He is going to tell us about albumin and the physiology of albumin, as well as tell us about landmark fluid trials that have been done so far that are providing guidance on the use of fluids and albumin in terms of patient care, resuscitation, optimization, stabilization, and evacuation of fluids. So I will invite Dr. Timothy to share his slides as we take the next about 5 minutes to respond to the poll here. And the first question in the poll is, beyond colloidal properties, which of the following is not a physiological benefit of albumin? Select all that apply. So whether it has antioxidant effects, protection of the glycocalyx layer, and extracellular buffering of acidosis, you can tell us. And then hypervolemia is in sepsis is associated with increased mortality. Is that true or false? Hypervolemia in sepsis is due to the following. And select due to the following except, so you have to select the one that is false, and then tell us if albumin administration improves mortality. What are your thoughts? And then in sepsis, at what serum albumin level would you administer IV albumin? And I think these questions will be answered by Dr. Timothy in his discussion. And he will also go through a couple of issues that we mostly concern ourselves with at the bedside to decide and when to give albumin. So we have about 2 minutes to close the poll. So if we hit 50% of the audience, we shall close the poll. If we hit the remaining 2 minutes, we shall close the poll. So whichever comes first will lead to closure of the poll. If you have any questions, please post them in the chat. Okay, so I'm going to close the poll in the next 10 seconds. We've hit our 50% target, and I thank the audience for responding. So in the next few seconds, I'm going to close the poll. All right, I will close the poll now. Thank you everyone who has responded. I will invite Dr. Timothy Moyembo to take over the presentation. Dr. Timothy, over to you.
Good evening, all. Thank you, Dr. Cornell, for the kind introduction. We're going to go through the story of albumin in ICU. So when, how, in whom, and the landmark trials. Am I audible?
Loud and clear.
Okay, so the outline will be as follows. We'll look at the background, the structure, and then the biochemical features, production, distribution, and degradation, physiology and pathophysiology, albumin administration in acutely ill, what is new, and then where next. Then to summarize, we look at the 10 myths about albumin, and then recommendations and conclusions. So a bit of background, albumin was the first human protein isolated and extracted from plasma for clinical use, first crystallized in 1934, available for clinical use in the 1940s. Early successful use in multi-trauma and severely burned patients led to rapid expansion to the emergency rooms worldwide. First commercially available preparations were developed using the cold alcohol fractionation technique. Refinements in extraction and processing have hence resulted in extreme and increasingly pure solutions. A bit of a structure, it's encoded along the chromosome arm of chromosome 4. It's made in hepatocytes, and this is as a pre-proalbumin, which has 24 amino acids on the N terminal. 18 of these are cleaved off to make now the proalbumin. So from pre-proalbumin to proalbumin, and then the remaining 6 are also cleaved off by furin to make the mature albumin. Mature albumin is immediately released into circulation without liver storage. This is very important. The mature human albumin consists of 585 amino acids. Okay, so there are 585 amino acids making the albumin. It usually has an N-terminal extension of 24 amino acids, 18 are cleaved off, then another 6 are cleaved off to make them mature. It's globular, heart-shaped, with repeated series of 6 helical subdomains. Again, this is very important. Plasma concentration is usually about 35 to 50 milligrams per mil. Some places you'll see 3.5 to 5 grams per deciliter. It depends on the units you're using. Half-life about 18 days. Very, very important. You'll find that this half-life is long, so you cannot use albumin as a nutritional marker. It's found both in extra and intravascular spaces, like the basic physiology has already told us. There are 3 main structural characteristics that are important here. So 3 components that give it its properties. So the cysteine residues have got a sulfhydryl thiol group, which has the antioxidant properties. How does it do this? It binds to ligands like copper, like iron, and then scavenges also oxidant residues. The other one is it binds to nitrous oxide. Now, nitrous oxide, you know very well, causes vasodilatation in sepsis. And HRS is hepatrenal syndrome. So you have a lot of nitrous oxide circulating. So albumin, via the cysteine residue, has this ability. The domains 1 and 2, of course, they have subdomains, A, B, and the rest, are responsible for transport. They bind to many molecules, as we're going to see. Then it has 16 imidazole residues, which are responsible for the buffer effect. You find that albumin has got a pH of 6.75, so it can either accept or release hydrogen ions. So it contributes to the buffering effect. And these are the structure and then the globular representation of albumin. Production, distribution, and degradation. Solely made by the liver, 100% in the liver, at a rate of 9 to 14 grams per day, and degraded at the similar rate, 9 to 14 grams per day in muscle, skin, liver, GIT, kidney, and others. Its median half-life we have seen is 18 days. Generally, at every 1 state, a person will have 300 grams of albumin distributed intravascularly. Now, there's increased concentration per liter of albumin intravascularly. You can see it is 40 grams per liter. And if you have 3 liters in the plasma, the total is 120 grams, okay? When you look at the interstitial fluid, there is less concentration of albumin per liter. However, because of volume of distribution, we have 10 liters. We eventually have 18 times 10, which is 180. That's why we saw that 40%, only 40% is intravascular, and then the 60% is in the interstitium, okay? Physiology, pathophysiology of albumin in humans. Albumin moves to the interstitial space by transcapillary filtration at something called the transcapillary escape rate. This is very important. It can be either passive filtration. Now we have seen that in large pore sites, for example, in the bone marrow, in the liver sinusoids, they have very large pores, so it can easily seep through passively. However, in other places, because of the endothelial glycocalyx, we can have also active filtration via what we call the Al-bonding receptor. So the endothelial calyx is not only physical, but it also has active transportation That's what I can say. And on the side there, we're trying to show the forces which have elaborately been explained. Okay. Pathophysiology continued. So 40% of total albumin is intravascular, yes. However, in inflammation, this decreases and the extravascular proportion increases. Why? You have a disruption of the integrity of the endothelial glycocalyx with widening of these pores. So you will have a seep through of the albumin. The transcapillary endothelial rate of albumin is an index of vascular permeability. So in sepsis, inflammation, trauma, as we're going to see, it will increase. Normally it is 5% per hour, but can double in surgery. This question was asked. Yes, surgery, trauma can contribute to that and may be increased up to 20% or more in septic shock. So the revised Stirling equation and debate of albumin versus crystallate continues. Now, to bring the physiology into practice, what happened? Studies of albumin and large clinical trials demonstrated that the perceived degree of plasma expansion is no longer believed to be 1 to 3, but in the range of actually 1.3 to 1.6. So the answer of 1.5 was correct. Also, the duration of intravascular retention isn't so much beyond the crystallate solutions. We have seen that. So the colloids such as albumin and the crystallate more or less have the same time of retention intravascularly. However, there's something called context-sensitive fluid IV administration. According to the context and with the knowledge of the endothelial glycocalyx integrity, you will know that I'm giving this fluid is not going to remain intravascularly, but I may increase the hydrostatic pressure beyond what is holdable, and then instead, even if I'm giving albumin, I may increase interstitial edema, as we're going to see. Clinical conditions associated with increased albumin, transvascular escape rate. So notably, I'll point out infection and sepsis, major surgery, trauma, fluid overloading. So making a patient hypervolemic, you may actually destroy the endovascular glycocalyx and cause issues. So nephrosis, cabbage, ischemia, and then burns. Physiological functions of albumin in the human body. A variety of essential functions are done. It regulates 75 to 80% of colloid oncotic pressure, regulates pH, like we have seen, has got anti-inflammatory and anti-apoptotic effects. These help in preserving microvasculature. So in one of the cartoons that have been projected, the endothelial glycocalyx has got some albumin, and which is protective. Someone was doubting whether albumin is protective. It's very protective for the endothelial glycocalyx. And other than just fluid resuscitation, at the end of this lecture, I hope people will know that albumin has got protective effects, especially in critically ill patients. So it binds and transports various bioactive molecules like protein, peptides, fatty acids, hormones, drugs, nutrients, and then chelates metal ions, like we have seen. Now, it's very important to look at hypoalbuminemia in ICU and how it affects a critically ill patient. Other than just resuscitation, this topic is about cardiovascular medicine and probably resuscitation, but you will see that albumin goes beyond that. So serum albumin level concentrations less than 3 grams per deciliter are hypoalbuminemia, okay? But should we saw the NEMO value 3.5 to 5. If you have a value slightly less than 3.5, should we correct? By now we shall see where we start. So it's very common in critically ill patients because of increased albumin losses. Usually in ICU, you may have a patient with GI or GUT bleeding. Albumin will also be seeping through. Increased capillary permeability, where you have a move from intravascular to the interstitial, which is third spacing, as we're going to see. Dilution due to excessive intravascular fluid administration, iatrogenically caused, okay? If you do not have end targets of your resuscitation, you're giving fluid blindly, then you may end up here. Poor nutritional status, mainly in critically ill patients, and then altered liver function. As we have seen, it is mainly produced by the liver and no storage. It's associated with, so hypoalbuminemia is associated with increased complications, reduced short and long-term survival in critically ill patients. Studies have shown this. And by the end of this presentation, I hope I'll have brought out this clearly. So it was found that for each 1 gram per deciliter decrease in serum albumin, there was associated increase in risk of death up to 137%, increase in morbidity up to 89%, increase in hospital length of stay up to 71%. So look out for low admission albumin levels. You're getting a patient admission in ICU. It would be prudent to know this patient has come with which albumin level. I know I may say a lot of new things here, probably controversial things, but it does not limit. If we do not have things to use, it doesn't limit what we should know. And if this is even giving any mortality benefit, maybe we may start practicing if we have it. So there's association between severity of illness cause and low albumin levels. Okay, moving forward, what does literature say on albumin use? So this paper by Jean Louis Vincent in 2014 tried to bring out the practices of albumin in critically ill patients since inception up to now. So we're going to look at them. As key points on the albumin story so far. So how did albumin come about? We have seen in 1941, first clinical use of albumin. Now from 1941, 30 years later, in 1975, the first randomized controlled trial of human albumin in 16 patients undergoing abdominal aortic surgery was done. To their surprise, they found that albumin was not giving the plasma expansion they expected of 1 to 3. It was about 1 to 1.5 or 1.3 to 1.6. After that, they started doubting role of albumin. Now the first meta-analysis, so between 1975 to 1998, first meta-analysis, about 30 trials was done in critically ill patients, and they found that there was increased mortality in critically ill patients who received albumin. Actually, this led to reduced use of albumin to about 50% in most ICUs. A study was done in UK and it had reduced. However, some people came up in 1999 and did an expert working party committee review, and they wanted to see, is this really too, is albumin this harmful? So between that time and 2001, several studies were done. Eventually, they did one in 2001, and after this, there was no effect of albumin on mortality. So mortality of albumin was neutral. So the first meta-analysis was in 1998. The second one is 2001. 1998, harmful. 2001, neutral. In 2003, another meta-analysis was done whereby they were correcting hypoalbuminemia to target 30 grams per liter. And this was associated with reduction in complications. So this was the first batch of earlier randomized control trials until 2003. Now in 2004, a large safe trial was done whereby they looked at albumin 4% and then a normal saline. And here, there was mainly no harm of using albumin. Albumin use was safe. However, there was no 28-day or 98-day mortality benefit. However, most important information here comes from the subgroup analysis, where there were 3 subgroups. Septic patients, there was some mortality in septic patients. Traumatic brain injured patients, there was increased mortality. And then ARDS patients that were hypoalbuminemic and were being weaned from the ventilator, there was some benefit, as we're going to see. However, the newer recent studies are the ERS study, where they tried to give albumin versus normal saline, and there was no benefit. You'll note here that the doses of albumin and the volumes were low. After the ERAS in 2013, in 2014, Albion study was done, where they looked at maintaining albumin above 30 grams per deciliter. They used higher doses of albumin, and they continued giving albumin over 28 days. After the 28 days, there was no difference in mortality in 28 days, and also no difference in mortality on 90 days. However, the difference was again in subgroup analysis. In the subgroup analysis, there was some benefit for septic patients. Now, after the initial RCTs and then the later RCTs, one meta-analysis was done to look at 3 big trials: SAFE trial, ERAS trial, and ALBIOS trial. And there was some benefit for albumin in severe sepsis. In between there, the other studies were done by people, and some of them were showing benefit, some were not showing benefit. So of the 3 meta-analyses, completely different and controversial results. The first one was against albumin in 1998. Second one was neutral in 2001. The third one in 2003 was in favor of albumin. Why this controversy? Probably there were many heterogeneous studies and patient selections, different points in time at which the fluids were administered, different doses of albumin like we have seen, and then different end targets of resuscitation. Some were looking at cardiovascular parameters, others were looking at metabolic markers of perfusion, etc. And then others allowed clinical discretion. So where next? 6 questions need answering. 1, what type of albumin preparation should someone use? So currently, available human albumin solutions are developed using various techniques. Hence, there's a lot of variation. You'll find that the acetylation, the cysteine, the additional amino acids vary, and then this will affect the properties of albumin. Maybe even the studies were affected by this. So what is happening? Genetically engineered recombinant albumin may eliminate such variations. So if you're looking for albumin, if you can have one of these albumins, maybe you'll get better results. Should albumin infusions target albumin levels? As you're giving albumin, should you target a level of 3 or 2? Now, this depends on your indication. We have looked at the difference between fluid loading, fluid resuscitation, and then supplementation. Now, if the patient requires resuscitation, you may not target a particular value because your aim now is to expand the volume. So you will give, and then you will not use a hyper-oncotic solution of albumin. You want to use one that is more or less similar to the crystalloids or plasma. So a less concentrated solution, maybe 5 to 4%. Okay. However, here you will not be, your end target will not be the value of albumin level. In supplementation, though, levels may be useful. For example, to guide your ongoing needs. We'll see the difference between resuscitation and supplementation. Resuscitation versus supplementation as a medication. So we have seen when you need to use it for resuscitation, large volumes, for example, of the 4 and 5% are indicated. For example, in the SAFE study, they were using 4%, which is hypo-oncoic, okay? And they were giving about 500 ml every 30 minutes and looking at the end goal-directed therapy, early goal-directed therapy targets, okay? Here you're aiming to fill the intravascular space, but for supplementation, you're giving it as a medication for other actions, such as improving on transport of your medications, antioxidant, microvascular preservation importances. So artificial colloids, so the heterstarch and then gelatins versus colloids. So this also came up. There was no benefit found for these in sepsis. In fact, they caused coagulopathy. They bind factor 8 and Willebrand's factor and can cause coagulopathy. They may lead to increased risk in AKI. So I wouldn't give them in a septic patient or anywhere. So which dose of albumin should we use? I think this one also came up. So determining the ideal dose of volume may be difficult. In fact, it's also not age dependent. Different studies use different doses, but many of them were not getting the target albumin for which we have seen reduction in complications and benefit of 3 grams per deciliter. Okay, so the ALBIOS study came close. So if you go back and read the protocol using ALBIOS study, will push you close to 3 grams per deciliter if you're using albumin as a supplementation. You want to reduce risks and complications. even some benefit in mortality, but it's not yet clear. Now, if you need a formula of albumin dose to be infused, it will equal to the desired albumin concentration minus the actual albumin concentration times the plasma volume. Which concentration of albumin we have already seen? If you are targeting resuscitation, then 4 to 5%, because that will be large volume resuscitation. Now, these 4 to 5% unfortunately have a higher concentration of chloride, and then they can affect your chloride concentration, but to a low extent. Now, if you have supplementation requirements, then you can use the 20 to 25, like we're going to see. Here they're saying that all preparations contain sodium, but this may not be very significant. Is albumin cost effective? Finally, this is a big question. Now listen very carefully. Albumin solutions have been found to have good safety record, at least after a safe study. They may be more costly, at least those days, but now in some settings, they're getting cheaper and even available. Nevertheless, if it is shown to reduce morbidity and mortality, it is likely that the cost effectiveness ratio would favor albumin administration in ICU. Now, albumin administration, in what way? Are you using it for resuscitation? Are you using it for supplementation? In ICU, you may have a patient who is not even hypovolemic, but has a hypoalbuminemia of 1 or 2.15. You may use it at supplementation. What are the most recent evidences? Now we have come from 1940, we are now in 2002. So there is a paper published in 2022, Understanding Disease, 10 myths about albumin. I'll just go through this quickly as we summarize. The first myth, albumin leaks from intravascular space into the interstitial compartment and contributes to edema. No, this does not happen. We have looked at the revised Stalin principle. So albumin at the arteriolar end, not even then, but throughout, will be seeping through slowly and then reabsorbed into the lymph and then comes back, unless there's a very big issue with the endothelial glycocalyx for massive leak. 2, albumin is less effective for intravascular volume expansion than the artificial colloids. No, this is not true. Albumin is more effective. The ratios that we have seen, if you compare albumin with the colloids, albumin will expand it by 1.5 to 1.6. The colloids may be 1.2 or 1.3. Albumin administration prevents acute kidney injury. Yes, in specific settings. Now, what are the settings? It was shown that in patients with severe or with liver cirrhosis and ascites, if you're doing large volume paracentesis, for example, removing about 5 liters of acidic fluid in one setting, and you do not replace albumin. Now, in this case, you'll be doing a supplementation of albumin with the hyperonchoic one. You will end up with an AKI, okay? But the studies were mixed. This will only help in patients who have this, and then maybe spontaneous bacterial peritonitis, but not extraperitoneal infections. Okay. However, this one also is time dependent. Okay. Albumin improves survival in sepsis, maybe, but is still uncertain. Why? We have seen that in most studies of albumin, there was no mortality benefit. The mortality benefits were in subgroup analysis of safe, albios, and then these other studies that were done. Okay, so in safe study, traumatic brain injury, albumin was actually detrimental. Albumin improves effects of diuretics, yes, but only temporarily. So when you have a patient with nephrosis and then hypoalbuminemic, you'll find that you will have issues with your diuretics if you want to improve the diuresis, because diuretics need albumin to be transported to the proximal tubule where the effect happens. So supplementation of albumin was found to be helpful, but this is also time dependent, only work for 12 hours. Albumin administration improves fluid removal during renal replacement therapy. Yes, it does. You find that patients who are hypoalbuminemic will not stand your dialysis. In a very short time, they will be hypotensive. So preloading them with albumin, about 100 ml of 20%, was found to improve intradialytic stability, and then hence improving ultrafiltration. Albumin decreases mortality in liver cirrhosis, yes, but only in specific subgroups, like I've said. So in patients with liver cirrhosis, you'll have ascites, sometimes you'll have SBP. If you're doing large volume paracentesis and you're not replacing albumin at a rate of 5 to 8 grams per liter of acidic fluid removed, these patients end up with AKI, okay? However, in other studies, if you already have a decompensated liver failure, there will be no benefit. Albumin increases mortality in traumatic brain injury. Yes, we have seen in SAFE and in subgroup analysis that traumatic brain injured patients, when they were given 4% human albumin solution, mortality increased. However, further studies were done which combined the same 4% human albumin, but with different oncotic pressures. And the one that had closer to normal osmolarity, that was not hypoosmotic, did not increase mortality. So it is not albumin per se that increased mortality, but it is the hypooncotic, whereby now you will have increase in what? ICP, okay? So 9, albumin substitution to correct hypoalbuminemia reduces mortality from all causes. Now, the catch here is all causes. This is not true, okay? We've seen that in SAFE, in Albios and all, even after targeting 30 grams for all patients, there was no improvement in mortality, 28-day and 98-day. The benefit comes in subgroup analysis. Finally, albumin administration increases sodium chloride load, probably, but not very relevant. However, what I need to stress here, like Dr. Cornell said, the low concentrations of 4 and 5 have got higher concentration of chloride, and this may raise your chloride. However, the higher concentration of 20 and 25 have less. Now, recommendations and conclusions. Members, although unlikely to cause harm, it isn't necessary in all critically ill patients. You need to reserve it for specific groups of patients in whom there's evidence of benefit. So albumin should not be thrown around in every patient, but you need to know the specific indications like we're going to see. So appropriate indications where there's wide consensus. 1, large volume paracentesis, which I've talked about, and then therapeutic plasma pheresis. So where you have large volume exchanges of about 1.4 liters per exchange, okay, you need to replace albumin. Spontaneous bacterial peritonitis we have seen in cirrhosis with SBP. So cirrhosis also with type 1 hepatorenal syndrome. So in hepatorenal syndrome, the liver cannot clear the vasodilator. So albumin will act as a scavenger. That's why in hepatorenal syndrome, we give large volumes of albumin for this. Ovarian hyperstimulation syndrome, and then according to the severity, as you're draining the ascites because of serositis. Septic shock we have seen after you've given a lot of pistols. So in the SAFE study, later on in the surviving sepsis campaign, after exhausting your crystalloid resuscitation, they are saying it is better to consider albumin as a colloid, okay, but not the synthetic ones. So in hypooncotic patients with ARDS, now there's SAFE trial has shown that whereby giving 25 IV bolus and then with some Lasix for about 72 hours. Okay, and then other protocols like PAL protocol where they used PEEP, albumin, okay, and Lasix. This improved oxygenation and then net negative balance and improved hemodynamics. However, did not shorten days to extubation. Then nephrosis with hypoalbuminemia. We have seen that the effect of diuretic will be very low if you have low albumin. So you're seeing that the effects and functions of albumin are not only in IV resuscitation. In IV resuscitation, you're going to use 4 and 5%, and large volumes will be needed according to your end targets of resuscitation. However, as a medication, as a supplement, you're going to use albumin. If you have levels, especially below 3, but more so below 2.5, I'll start to replace albumin because of these other important effects. In summary, as evidence, the latest evidence shows there are areas where you may have harm of using albumin, for example, in acute brain injury. But again, remember, it is the 4% albumin. So I don't know if you give a patient 20% albumin, what the effects will be. So all these are gray areas, okay? Also with the 4% albumin, what is its osmolarity? Those are gray areas. However, there's no evidence in extraperitoneal infections. Remember, in liver cirrhosis, we are saying if you do not have SBP, your albumin may not help. It usually helps if a patient also has SBP. So possible role, but evidence is limited or uncertain. So we have seen in nephrosis, there may be a possible role. We have seen in post-cardiac surgery, there may be a possible role. And then general septic patients, a possible role. Finally, the conc recommendations of albumin use in critically ill patients. Now, sepsis resuscitation after large volumes of crystalloid. You've given your crystalloid at 30 ml per kg. However, I'll look at my dynamic parameters of resuscitation and then target those ones. If I find I'm still giving a lot of crystalloid, if I need to move to a colloid, then it will be albumin. However, when do you decide that I've given a lot of crystalloid, I should turn over? It's not very definite. Now, in spontaneous bacterial peritonitis, yes, we have seen. So cirrhosis with the ascites and spontaneous bacterial peritonitis, albumin will help a lot. Then hepatorenal syndrome, particularly type 1. Okay. Then large volume paracentesis, you're removing more than 1.5, more than 5 liters. So you replace 5 to 8 grams per liter that you've removed of that 5 liters. Okay. And then ultrafiltration in patients with hypoalbuminemia. Okay, I think that is my presentation. And thank you very much. Cornell, over to you.
Excellent. Thank you very much, Dr. Timothy. So I think I'm going to leave some of the questions to Dr. Erasmus to respond to. We'll request you, Dr. Timothy, to respond to the poll question here. So number 1, beyond colloidal properties, I think we've covered that. Albumin provides protective aspects to the glycocalyx and as well as buffering and antioxidant among other benefits that you've mentioned. And it's mitigated very well, but is associated with mortality if it is very low. And we have to be cognizant of that, and as well as the mechanisms that will lead it to be low were also well elucidated. Albuminuria in septic shock is not usually the fundamental reason as to why albumin reduces. It's largely to do with capillary leakage, catabolism, reduced production, like Dr. Timothy elucidated quite well. And I think the aspect on administration having mortality benefit, Dr. Timothy, we have a 50-50 from the audience. I think here I will invite you to again make some comments.
Okay, thank you, Cornell, for that. Like I said, there are a lot of controversial issues here. And as you go further and you start to look mainly at studies, you look at what people have done, what methods did they use, in what population, and then you interpret them according to the patient you have, the resources you have, and your setting. Now, so far, all the studies were not showing a benefit if you combine all the big studies. The benefits are in subgroup analysis. whereby, to my thinking, if I target an albumin above 3 in a critically ill patient, maybe I'll increase the patient's chances, because some of the studies, like in Albios and then in SAFE study, they showed some mortality benefit. Okay, but it's in the subgroup analysis. But from the physiology, you have seen that albumin has got protective effects. So other than the resuscitation, a critically ill patient needs to maintain a certain level of albumin to give them better chances. If I have all the resources, I would give the patient the best. That's what I can say simply.
All right. Thank you. Thank you very much for that. And then the final question was, in sepsis, at what serum albumin level would you administer IV albumin? And I think you talked about this in various ways. 58% of the audience says under 20%. That's the majority. So I will ask you to make some comments to that for a final take home on albumin therapy.
Okay, so in sepsis, what serum albumin level would you administer IV albumin? This question is kind of a trick question. It's combining two things. In sepsis, I'll expect a patient who is hypotensive and requires resuscitation. So you need to know the indication of your albumin use. As you're getting the patient, does this patient need resuscitation? So if a patient needs resuscitation and I want to bring up the map, I want to bring up the targets of the end goal of the early goal-directed therapy, I will not look at albumin levels. I'll give this patient 4% or 5% albumin, which I'm going to use as an IV fluid resuscitation, and give them maybe 500 ml, reassess after 30 minutes, give another 500 ml to bring up the intravascular volume. However, if I've had a patient who has now stabilized, is critically ill, but has ever had sepsis, I'll look at the albumin levels. And we have seen from studies, albumin levels that are below 3. But most importantly, if you go below 2.5, which is now about 50% reduction in albumin, it is better to bring up this patient's albumin level to above 3. Maybe they stand better chances. So you need to know what indication, what am I using the albumin for, and then what type of albumin. Am I using hypooncoic? Am I using hyperoncoic or hypoosmotic and the like? So that's what I can say about this.
Right. Thank you very much, Dr. Timothy. That is well said, and I hope the audience has understood that it is not one size fits all. All right. I will, at this point, I invite Dr. Erasmus to make a final comment on submission, and then can bring this discussion to an end. Dr. Erasmus, over to you.
Thank you so much, Dr. Cornelius, for moderating, and a big thank you to the to our presenters today. Particularly, thank you, Dr. Timothy, first for honoring our invitation, but also for the beautiful presentation on albumin. It's quite a big and definitely confusing area where we default to, you know, to correction of numbers sometimes. I want to just make a few comments, and I'm going to do this in form of a presentation as well, just quickly, then we shall conclude in a bit. Someone is still sharing. Dr. Timothy, could you leave? All right, thank you. All right, so basically what I'm going to talk about is really what guys have been talking about already. I've just put together a few pointers from the key statements made today, and a reference here to a very important reference, a very important link to fluid therapies that could teach us a lot more. So to start with, we definitely know that our capacity for keeping fluid in our bodies is not infinite. as a 70 kg person who is healthy and is a man, not like the man on TV that we've seen recently, fleecing people. You've got just about 42 liters of fluid in total body water, kind of, and that is distributed between the intracellular and the extracellular compartment. The extracellular compartment contains only about 14 liters, and the intravascular compartment has about 3 liters of fluid circulating at a given time. Of course, there are ranges, and the larger you are, the bigger you are, perhaps, with less fat on you, the more blood you might have. If you're female, if you're elderly, if your blood volume may be different. If it's different for children as well. But generally, what I'm trying to say here is that there's an infinite amount of capacity of our vascular system to keep up with all these volumes. So whenever we're giving people fluids, we have to ask ourselves, where is it all going? Where is it all going? Because that's not cool to just, make people so edematous. Anasaka is bad medicine. It is the work of the devil. So we have to try to avoid it. In some circumstances, it's not avoidable, but as soon as we're able to come out of that, we need to quickly start to get patients out of this state. Because as the speakers have already mentioned, there is evidence that every day a patient is positive in terms of fluid research, in terms of fluid status. They are actually getting increasing mortality, partly because of the fluid itself, but maybe because of the conditions that are making them more positive. Now, we don't help it with our behaviors around the use of fluids. We seem to think fluids are extremely innocent. We seem to think they are not harmful, but the effects are extremely bad and they are very deleterious. Every morning you see your patient look like a Michelin baby, you know that they may not survive, and that is most likely because of you. You have killed that patient. So, fluid stewardship. Dr. Peter took us through this, a coordinated series of activities intended at making sure you're using fluids for the right, the appropriate volume of fluid for the right reasons, for the right duration. And as soon as it is out of need, you are getting it out so that you prevent the complications and the cost involved. So that is really what you are trying to do. So here is a link, something called there's an International Fluid Academy that teaches nice stuff around fluids, and the link on the screen is quite a good one. And if you go on Google and just Google up International Fluid Academy, you should be able to go through to that site, and they'll be able to give you some pointers on how to handle fluids in patients and hopefully have a more common sense approach to caring for patients who require fluids. Yes, so there are very many myths we have built over time around patients who require fluids in our units or whom we want to give fluids. When a patient is septic, we think they're always hypovolemic, so we want to torture them with the fluids, and definitely we are killing these poor people who would otherwise just get out of their E. coli and go back home. But because now they end up with a cycle, a weird vicious cycle that, of course, with our weird use of fluid, they may stay in hospital and sometimes they don't leave hospital vertically. Similarly, we think people who have sepsis have ongoing insensible losses. We think that people who have got a low preload, when you measure it, always means you must give fluids. People who are edematous were like, okay, now I'm worried, let me give diuretics. We've already learned that, edema doesn't necessarily mean that the patient's intravascular volume is excessive as well, relative to the cardiovascular system. Here, I would like to comment, I think one of the poll questions was asking if a patient who is edematous can be hypovolemic. So we really need to be able to define the word volemia. Volemia means volume inside the blood vessels. And actually there are some experiments that have estimated that patients who are having increased total body water actually have increased intravascular volume too. So what actually does happen is the relative interaction between the vascular tone and therefore vascular capacitance, and then is what causes that relative picture that tells us that the patient might be, might actually be responsive to more volume. Doesn't mean that they're hypovolemic. It just means that, when blood is circulating through their vessels, the vessels are dilated, perhaps particularly in septic patients, the vessels are dilated, and the volume inside them looks less than it should be. The tone of the vessels is low, so it's not really the mean systemic filling pressure is low in them for other reasons. So in that case, you might see signs that you'd see the patients hypovolemic, but actually the total body volume of these patients is higher. Of course, we don't have a very accurate way of measuring intravascular volume, but some isotopic studies have been conducted in some of these patients. People with nephrotic syndrome, people with increased body water due to edema, maybe out of sepsis. They have actually found that in many of them, they have increased total blood volume than the regular person. And then surgical patients, we like to discharge guests out of theater on that ratio of 1:1:1, dextrose to ringus lactate to normal saline. I don't know who started that stuff. And I think that person, in the ERAS protocol, has been brought a lot in surgical care and is changing a lot of the dynamic of care in patients in surgery. So now I don't see a lot of these interesting prescriptions, but I see it a lot in obstetrics, though, where colleagues like to send their patients out on certain ratio of dextrose to normal saline or something like that. I hope that today changes it. It's really it's not personalized treatment. It's not safe. Fluids are drugs, like we've been told. So you have to treat them like drugs, the same way you treat other drugs. So therefore, you must always ask yourself, when should I start fluids? When should I stop them? When should I start removing them? And when should I stop removal of fluids? The 7 Ds matter. What's the dose? What's the diagnosis? What's the indication? What's the duration you must give it for? And when it's done, how do you get it out? How do you discharge the patient out of that need for it? So you must always follow that. And Dr. Peter took us through the resuscitation aspect. Sorry, this protocol of resuscitation, which follows the 4 stages. The resuscitation stage, where you're giving fluids aimed at restoring intravascular or circulating blood volumes adequately enough to sustain cardiac output. In this stage, you are assessing the patient for fluid responsiveness as well as fluid tolerance, so that you can continue with fluids if needed. And also thinking about other mechanisms that could be in action in the patient's case, so that you may have to introduce other interventions like vasopressors, inotropes, among other things. Remember, a patient who's hypovolemic initially could be masking other mechanisms of shock that you need to attend to. Prolonged hypovolemic shock itself will increase the amount of lactate in the body, and the lactate has got a vasodilatory effect on the patient's vessels, which are going to mess up with the vascular tone, which might benefit more from early introduction of inopressors on this patient. So you have to keep assessing your patient and giving the right personalized therapies. There is no right answer. It is just what a patient needs at a given time. Same patient may need something different. Of course, you move to optimization, stabilization, evacuation, and so on. We have been taken through this, but remember, at all times, a cyclical process of assessing the patient's subperfusion state. Just because the patient is fluid responsive doesn't mean the patient needs fluids. The patient must have an aberration in their circulation that could benefit from giving fluids. In other words, they should demonstrate signs of shock, perhaps, so that you can give them a fluid bolus. If they're not in shock and they still kind of behind the volumes as estimated from assessment, maybe you might go to optimization maintenance later on as soon as possible, and then prevent any further losses, among other things. Keep assessing the patient continuously and target your therapies. In patients who are bleeding, hemostatic resuscitation is what we need in our setting. In some countries, they've got a lot of blood products. In our setting, we don't even have the products we need for one patient at a given time. When we are doing massive transfusion, a patient comes, like this patient was presented to us. That patient seemed to be a case who needed probably massive transfusion, given how they presented. In our setting, you probably cannot do that. So you want to initiate the most aggressive hemostatic interventions. That means damage control surgery, stop bleeders. Let surgeons work with the anesthesiologists, with the emergency physicians. Put in your fluids carefully until there's better hemostasis. Then open the cups, among other things. Put in things that can decrease fibrinolysis and prevent ongoing medical losses of fluids, prevent the triad of shock, the triad of trauma, that is the hypothermia, acidosis, and I don't even forget the third one, like life is harsh. But yeah, try to prevent that and support the patient so that they don't continue losing. Adjunctive use of vasopressors, early introduction of vasopressor might avert the vasodilatory effect of shock in patients and maintain patients perfusing even with a limited input of volume in them until such a point when the volume is adequate and can actually take you to the point of full resuscitation earlier than if you just chase the patient down with just fluids. Assess fluid tolerance, assess fluid responsiveness. Remember, fluid tolerance just means that, if you put fluids in me, I will not die. I will not die. That's what the patient's telling you. If you put more fluid in me, I won't die. I can tolerate it. Fluid responsiveness tells you that if you give me fluids, I might actually improve my cardiac output as well. So the two things must match for the patient to actually likely benefit from fluid. Otherwise, if the patient is fluid responsive but not fluid tolerant, then that may be a problem. If a patient is fluid unresponsive especially, then you give more fluid, you're then going to a red zone in this case where the patient is going to get fluid overloaded, they're going to get edematous, they're going to get edema in the viscera as well as in the tissues. Now, once you finish getting the patient out of shock, you want to start to maintain the patient, and maintenance really addresses the daily needs of the patient in terms of volume, in terms of electrolytes, in terms of nutrition. So you need to calculate them appropriately. And this calculation also factors in the fluid creep that Dr. Cornelius talked about earlier on. So the medications you're giving the patient, the flushes you're giving the patient, we tend to ignore them. But these are things that together sum up to a very large amount of volume that may over time actually make the patient post when you're wondering, you're maintaining a fluid balance chart. The patient looks nicely well balanced, but the patient's putting on weight. Patient's becoming a Michelin baby. Patient is weeping from their skin. But that's because you give them some indirect gains of fluids. And maintenance fluids don't have to be intravenous. Anybody who has got a patent esophagus or an esophagus into which you can put a nasogastric tube and has got good gastric motility should be getting their fluids through the enteral route. That should be the primary route of giving them fluids. Start feeding them as soon as they can feed. Start giving them fluids via the energy. Now, albumin, Dr. Timothy has given us a very nice talk on this. I would just like to reaffirm, hypoalbuminemia is not a sign of need for albumin infusion. You must be targeted. You must know what you're trying to deal with. In fact, in most patients, I will differ a little bit here from Dr. Timothy's presentation. In most patients, in whom there is not a disturbance, there's not a primary problem in terms of synthesis of albumin, you have to treat hypoalbuminemia as an acute phase reaction. It's an acute phase reactant. In that one is a negative one, in that when a patient gets inflamed, they actually reduce the albumin because start catabolizing it, it drops rapidly in the body. And that's something to note. So replacing it is not addressing the problem. There's actually more money in trying to treat the problem causing the low albumin. I understand that we want to have so many thresholds on when start giving albumin, and there are probably some, consensus, guidelines on when to start. But in my opinion, a big part of it is really, the push to you box here. We just want to correct numbers, be very happy with the numbers, that our numbers look good. But the reality is that for albumin issues, you really, for most patients, you just want to attend to the underlying problem. Is there a number of albumin that might be very concerning? I think there's a number that makes a lot of us very uncomfortable, but should we be acting because we are uncomfortable? Is there really undisputed evidence that albumin is going to be extremely beneficial, especially in resuscitation of these patients? There's actually no resounding benefit. Matter of fact, when you hear or read in a paper and they are saying meta-analysis, subgroup analysis, among other things, somebody is in denial, and they are mostly looking for signals of benefit to at least continue searching for something for this. But you see, a very beneficial intervention should immediately show its results, and you probably don't need thousands and thousands of patients to delineate its benefit over a therapy that may be extremely cheaper. So medicine must achieve outcomes at the most cost-effective approach possible. And as for now, there's not significant resounding benefit of albumin infusions over crystalloid resuscitation of patients, but you can use it as an adjunct, particularly if you're using a lot of volume and you want to start cutting down the volume you're putting in. Again, the ratio of 1 to 1.5 between albumin and crystalloids is really not very, very exciting either, and you have to put that into your plans as well. Should you be chasing a bill of 300,000 per, or whatever cost per bottle of albumin for the limited slight benefit you might get, or you might be focusing on the underlying cause. Many times when we are over-resuscitating with crystalloid, it means that we have missed a step somewhere in adjudging the cause of shock, or actually stopping it. The patient could be having ongoing losses that we haven't diagnosed. Maybe the patient is bleeding. Maybe the patient is, the patient is vomiting, having diarrhea, and you need to address that. And that should be able to restore the patient's perfusing volumes, and perfusion without necessarily needing any more heroics. However, in patients who, like Dr. Timothy mentioned, in patients who have got liver failure, patients who are losing protein in terms of nephrosis, patients who are having protein losing enteropathy, seems there may be benefit in replacing it. And again, in patients where you're doing large volume paracentesis, among other things, for sure, you would probably want to put albumin there as one of your adjuncts for therapy. But when it comes to, and also replacement, definitely, but, the question always is, what are you trying to achieve? Does the patient come into you with a primary albumin deficiency, or is albumin merely a symptom of an underlying disorder? So it is key to always chase the underlying cause. That reduces the cost of care. And ultimately, the fluids, the drugs that we use in medicine are not in competition with each other, which means that we cannot necessarily say one intervention is more beneficial than the other. Rather, it is our thinking, it's our decision making that is at competition with death, with morbidity. And if we make the right decisions for patients at the right time, in the right patient, right time, then perhaps we might be able to pull them out with the right intervention. So sometimes, for sure, and similarly, when it comes to other crystalloids, we've always had these crystalloid walls, ring balance versus this. It comes down to what the patient's issue is, and it ceases to be more about which fluid is better than the other. Fluids are not in competition. We need to be the ones who are in competition with time, that against morbidity and mortality in the way we make decisions that can be personalizable to patients. Every intervention, just like every drug, must have a stop time. And when the fluids are no longer needed, you must stop intravenous fluids. You must transition to oral fluids. And even the oral fluids, you must be able to transition to regular nutritional intake of feeds and fluids, not necessarily therapeutic calculated, as long as the patient is able to take them in a way they can tolerate. Monitor the patient, review, repeat, review, repeat, review, repeat. And finally, remember, this patient is not just a hemorrhagic shock. This patient is not just a hypovolemic shock. This patient is somebody who has got multi-system involvement from disease and from whatever caused that hypovolemic state. And so you must institute general care issues. Some patients might need to address the underlying issue of sepsis with the antibiotics or control, among other things. Patient who's bleeding might need to go for surgery, then come out with multi-system support in terms of DVT prophylaxis where necessary, GI prophylaxis, nutrition, among other things. It's key. Remember, fast hugs, every day. Sorry, twice a day, please. Fast hugs BID, please. The mnemonic exists on Google. You can always find it. And these are some of the general comments I wanted to make quickly before I respond to some questions that were answered earlier on. There was this question on how do we, regardless if a hypovolemic edematous patient. Again, I would really like us to just look at the literature on the subject. There are studies that actually refute the idea that a patient who is edematous, who has got increased body water, is hypovolemic. It actually just means that these patients, their vascular physiology may be deranged, and as such, they may be too vasodilated, and maybe they may be fluid responsive in terms of assessment. They may have a collapsed IVC, but doesn't mean that total volume is low. So you need to ask yourself, if that patient gets hypotensive, what is the problem? Do they need a bit more fluid to be put in them? For sure, consider it. But if the patient needed fluid, they might be able to, to get some of this fluid back into their circulation through the lymphatics. In sepsis, for example, the first system to be affected is the lymphatic system. This system gets paralyzed quite early in sepsis, and that's why these patients still seem to, hyperfilter in these tissues, but they can't return quickly enough into their circulation. And then the RAS gets active, they start retaining sodium, retaining water, and the consequence is a Michelin baby, especially as you're throwing in more fluid. So addressing the underlying issue is what matters in these patients, and early use of vasopressors really helps. So I don't give them too much more fluid, because that positive fluid means tissues are strained, the interstitial pressures are going up, and that's going to disrupt the healing of tissues, among other things. But definitely if the patient is crashing hemodynamically, maybe fluids might be your adjunct, but you need to be diagnosing them. Use your test of fluid responsiveness. Try to diagnose the underlying mechanism of hypotension or shock in the patient. It's not always hypovolemia. Similarly, in patients who are anaphylactic, now the primary pathology in anaphylactic patients, the muscle degranulation, which is causing massive leak. So yes, they will have a relative hypovolemia, but the first and most important thing in these patients is really to shut down the muscle degranulation while stabilizing the vascular tone using adrenaline and histamines plus steroids. Fluids are useful. You can give them, but remember that once you've arrested the anaphylactic process, they're going to return that fluid and they should be able to pee it out. But if the fluid you give them is excessive, all that fluid is coming back to the central circulation, and then they will struggle hemodynamically in terms of their heart to handle that fluid. And so you might want to be very keen on the stage when you might want to start resuscitating them quickly with diuretics. It's quite an interesting type of shock to manage. If you remember in our introductory talk on hemodynamics, we talked about the mnemonic for shock as S being septic shock for anybody who has got warm shock, and patients who have got cold shock and low JVP must be hypovolemic. Patients who have got raised JVP and cold shock may be obstructive or cardiogenic. So in that case, you listen to the lungs. If their lungs having crackles, then most likely having cardiogenic shock. If they're having a high JVP, but the lungs are not wet, they must be having obstructive shock. So you must diagnose quickly whether it is tension pneumothorax, tamponade, or PE. Once you're past that part, the K is combination shock, misspelled with a K. And that K means that you have types of disorders that can manifest in multiple mechanisms. Anaphylaxis is one of them. There will be vasodilatation. There will be hypovolemia, true hypovolemia as well, because of the little fluid they have is probably shifting to another compartment. And they may actually have a cytokine or a cytokine injury, or a catecholamine induced injury to their myocardium, in which case they might end up with a Takotsubo and they'll be in like cardiogenic shock. So in those guys with anaphylaxis, it's really key that you're trying your best at all times to assess them actively, make diagnosis actively to direct your therapies. So that's how I would approach a patient anaphylactic shock. I think Dr. Cornelius will say, Dr. Timothy handled the aspect of paracentesis with albumin, quite an important area of need for use of albumin. Now, most guidelines and most of us health workers are seeking a number. I've heard from the questions we're asking, how much do we give? How much do we give? What number do we want? No, patients are not numbers. Patients are a physiological continuum that you should assess continuously bedside and determine where they sit so that you can intervene appropriately. And sometimes intervention may mean doing something actively. Sometimes it might mean folding your arms and watchfully waiting. You don't always have to do something. So thank you. Those are some of my quick comments on the presentation today. Dr. Asimwe, thank you so much for getting us this case. This is quite a classic case. It's quite common given the burden of trauma that we face in the country, and that you guys have to face that every day. I'm hoping that people are inspired to read a lot more, and I'm hoping in our different practices, we can try to figure out how we can be doing interventions to people who are massively bleeding, particularly these people with massive hemorrhage, obstetric patients. Dr. Adam Kiza is an obstetrician. I'm sure every now and again they get people with ruptured uteri, people who've got PPH. They need active, quick interventions, and yet we're in a setting where we don't have enough blood products. Every unit should probably synthesize a massive transfusion protocol to follow and a system that they can activate. Then for patients who are not bleeding, you need to be able to pick up the course quickly. Some patients are just not drinking, but you give them diuretics every day, and then you find them when they have decompensated. Those are probably quick. You give them their crystalloid and they pick up quite quickly. Some patients might be the ones who are having diarrhea, especially in children who have very limited total body water, and then they pour out that in one motion and then they decompensate quickly. So thank you for that talk. Let's read more around that. The Sterling principle. Sterling principle. Yes, sir.
I've forgotten to say Ebola patients.
Oh, yes. Thank you. Yes, so right now we have Ebola going on. And first is a real tragedy that we've lost so many people. The number of losses already one too many, and particularly we're losing health workers. These are people who are actually getting hit in the line of duty. And I'm hoping everybody is taking good care of themselves. Again, these guys lose volume. First of all, they hyperventilate at some point, and then they start bleeding from multiple areas. So the intervention for them really needs active resuscitation, which I believe should be multidisciplinary. Unfortunately, because of the kind of disease it is, there seems to be more efforts in terms of getting too many people in just to protect many people, but it is key that these people get resuscitated quickly. With a classic case of hypovolemic shock or hypovolemic resuscitation was with the cholera epidemic, and we had that earlier on in the presentation. And this is especially with people, with pediatricians who take care of children. But definitely even the adults, we get these kind of situations, especially patients who have been in ICU for a very long time. They've been on a lot of antibiotics, and then they end up with the C. diff diarrhea. Maybe you have patients who have got food poisoning, and they are diureting out their cardiac output, I would say. Just remember that in the adult patient, especially the elderly one, they have other comorbidities and are not going to tolerate a change in hemodynamics for a long time. So while they might start out with hypovolemic shock that you delay to intervene upon, by the time you come to them, they might have got an MI from their sympathetic response to this issue. They might have gotten, a stroke from a low flow state, among other things. So you need to intervene in a timely manner. The Starling principle has governed fluid therapies for a very long time, and it's key to understand the old description so that we understand the modifications that have been made in the modified Starling principle, especially with the discovery and the good description of the Starling, of the endothelial glycocalyx. We don't know a lot yet about fluid dynamics and fluid therapies. We are learning a lot, but we are learning a lot more now. Now, there are different types of fluids we use in medicine. You need to get to know each of them. You need to understand what their effects might be and when they might be benefit to your patient. I'm not going to start a battle on which fluid is better than the other, because there's no fluid that in itself is better than the other. What is better than the other is a decision you make for the patient at the right time on a good assessment. And then we had a talk on the resuscitation approach, the ROS protocol. And finally, Dr. Timothy gave us a very nice introduction and as well the detailed conversation on albumin. So thank you so much to our presenters. We've had quite a nice and big audience up to this time. So thank you so much, the audience, for being here, participating. These have been very nice questions. I know you have so many more. Keep asking them. If you need to, you can still email your questions to the AAU so that we can answer them maybe the next conversation. Other than that, next week we introduce a new topic. It's still on ICU cardiovascular medicine, and in that we are now going to talk about, just a moment, let me pull it up a bit. Yeah, so next we shall be talking about the people's ventricle. That's the right ventricle, and its functions in an in-depth manner, just so that we understand that while the left ventricle is important in pushing blood around our bodies, the right ventricle is that quiet brother it has that could mean life and death in some patients when it refuses to function. So come back in your big numbers, read around the topics, and let's meet next Friday. Thank you and good night for now. Bye-bye.